Good morning, everyone. On behalf of Match Coalition, thank you for joining us today for our spring virtual health briefing promoting better maternal health outcomes through digital and communication technologies. I am David Graham, the Director of Government Relations and Connected Health Policy at HIMSS, but more importantly, I am one of the co-chairs of the Maternal Applications of Technology for Community Health, or Match Coalition, the host of today's briefings. My other co-chairs who you've seen up here are Fran Ayala and Elizabeth Frazee, who you'll hear from later. To kick things off for today, we are joined today by our wonderful speakers for our fireside chat. First, we have Congresswoman Robin Kelly, representing Illinois' 2nd Congressional District. Congresswoman Kelly is Vice Chair of the House Energy and Commerce Committee and serves on the Health, Energy, and Consumer Protection and Commerce subcommittees. And her energy and commerce work is focused on expanding access to healthcare, consumer protection for the American family, and economic development. Additionally, she sits on the House Committee on Oversight and Reform, the House Democratic Steering and Policy Committee, and also serves as chair of the Congressional Black Caucus Health Brain Trust and co-chair of the Congressional Caucus on Black Women and Girls. Congresswoman, thank you for joining us. And joining her for the fireside chat is Dr. Nicole Williams. Dr. Williams is a board-certified gynecologic surgeon specializing in obstetrics and gynecology and is the founder and president of the Gynecology Institute of Chicago. Dedicated to the welfare of women, Dr. Williams has traveled to the Dominican Republic, Rwanda, Haiti, Cambodia, the Philippines, and Ghana to perform necessary gynecologic surgery on those in need. Dr. Williams, I will turn the floor over to you.
Thank you so much, David. Hi, Congresswoman Kelly.
Hey, Doc, how are you?
I am fine. It is so wonderful to see you, and it is really an honor for me to be able to host this fireside chat on one of our shared favorite topics, which is maternal health overall. And let's just get started. So let's jump right in. And I want to start with a personal story on how I kind of got involved in this, not only just being an OBGYN. So when I was a brand new baby attending, doing one of my first few night calls in the first few months of my career, I was called down to the ER to do a postmortem C-section. What that is if the mother is recently deceased and the baby's still alive, we can salvage the child. I was called down and they were working on her, and I'd never seen anything like it before. And everybody kind of knew inside that she was already gone. And then it was my job to check on the baby. And the baby was also dead. So that was one life snuffed out and another life never to begin. And that's when I started realizing, hey, you know what? This is an African-American woman. I'm at Mercy Hospital in Chicago, which is an underserved hospital. This shouldn't happen in America. And that's how I got involved. And that's how I ended up doing the ACOG lobbying. And that's how I was able to meet you. So that's my personal story. But tell us, Congresswoman Kelly, with all of the things that you're dealing with, what keeps you in this fight? So first of all, what got you into this fight? And then what keeps you in this fight?
You know, to be honest, I never, ever realized this was such a problem in the United States of America. Couldn't even imagine this was such a problem and didn't know that it was even more of a problem for Black women. I guess I shouldn't be surprised. But I was contacted by a friend and she asked me, did I know about this issue? And she spoke with me about Judge Hatchett and what happened with her son, Charles Johnson, and his wife.
Yes.
And she said that the judge could not get, any attention or anything going. So she put me in contact, and then my staff and I and Judge Hatchett and her son, we worked on a forum. And we put the forum on in October 2017. And as the time went on, I learned more and more. I met you and just heard how devastating the problem really, really is. So that's what keeps me in it, because, no woman should die because she wants to be a mother. That just makes no sense. I'm a mother. My husband and I have 3 girls between us. 2 of them have children, but when the last one had a child, he'll be a year in June, I was really worried, because I knew more about the situation. And my biological daughter, who hasn't had a child yet, so it is very worrisome. And then I've heard, more stories. I just heard from a friend, another mother that died. So that's what keeps me in the battle, because in the richest country in the history of the world, with fabulous doctors, our mamas should not be dying, and our families should not be going without, a partner, a wife, a mother, whatever the case may be.
Exactly. Just a few statistics for the audience so that everybody's kind of on the same page, so we understand the gravity of this situation.
Sure.
So in the United States of America, 1 in 700 women are going to die with a pregnancy associated condition. Now, when you add African American women to that equation, it is 3 to 4 times that. So this is a crisis that has been in the making for years. And you, Congresswoman Kelly, have gotten into this fight and are doing some pretty amazing things to help fight this. And we know that this is a long fight. It's not going to, be healed instantly. But here, tell us about some of your legislative victories thus far in this fight.
Well, I started off with a bill called the Mamas Act, and that bill dealt with best practices, having review committees, because we had heard, cities that had review committees, their rate of maternal mortality went down, and dealing with ACOG and folks like you in the profession. We were told the postpartum period needs to be expanded from 60 days to 1 year, and that would help tremendously, in decreasing deaths. And then, I don't like the word culturally competent, but maybe I'll say culturally informed. We needed more of that, because why is it that Black women were dying at 3 to 4 times the rate? And in places like Illinois, 6 times the rate, Indigenous women in the state of Washington, 8 times the rate. So 3 to 4 is the average, but in some places it's more than that. Why was this the case? And there needed to be more culturally informed people. Not that you had to always look like the person, but at least understand the reality of their situation. Even though it's improving over and over, people do better when it is someone that looks like them. And so that was the essence of it: the review committees, best practices, culturally competent, expanding, Medicaid. And then also something we've been working on since I've been the chair of the Brain Trust, which fits in here, diversifying the healthcare pipeline. What can we do to get more people of color, in these positions? So that was the Mamas Act. We couldn't get it out of committee, like it was, unfortunately, even though people that didn't vote for it, their states had some of the highest, maternal mortality. But, we just couldn't do it. The other part of it was improving data, because the more data informs policy and the more data that you have, then it could help you prove, the point that you're trying to make. So, so that was the Mamas Act. And then we wanted to fund grant programs to help people, get to where they needed to be, as far as did they need help, money, resources for data collection and training and, different things like that. So, but that was a long, hard fight, with the Mamas Act. And then actually it was split. So it went from the Mamas Act legislation to the Maternal Health Quality Improvement Act, which is based on the Mamas Act. And I'm happy to say, though, victory, that we got much of that signed into law under the appropriations bill. So there'll be grants.
The omnibus bill, right?
The what?
In the omnibus bill that came out, right?
We got it passed under that. And for the Mamas Act and Medicaid, we have it passed in the American Rescue Plan, but it's if you want, and then it'll end in 5 years. And it's in Build Back Better that it says not you may, but you have to, you have to do it, and it'll go on, it'll be permanent. So as you know, Build Back Better didn't pass, but states are stepping up. I spoke to Secretary Becerra, and more states than we thought, are stepping up. And I'm proud to say Illinois was the first state to cover for the 1 year period, but more and more states are stepping up.
Yeah, it's really important that, we have 49 states with maternal mortality review committees right now. But I think one of the big problems, and here we're talking a little bit about technology and how that can help to inform and bring us more data. So then we have that data in order to make policy at the grassroots level, at the hospital level, at the clinic level, in order to make sure that we're actually going to make policy that makes sense. Well, if we don't have the technology to aggregate the data, and we need states to be able to communicate with one another. Now, I know the CDC does have a standard for that, but how could you see using technology in order to help advance this cause?
Well, we actually have a bill evaluating disparities and outcomes of telehealth during the COVID-19 pandemic. Legislation, including a report on telehealth utilization, expenditures, and access to care and more. And it directs the Medicare Payment Advisory Commission to examine telehealth utilization, expenditures, payment policy, and impacts on access to care and quality for Medicare beneficiaries. So this study may further break down telehealth utilization data by services provided, provider type, geographic location of patients and providers. It also directs the Office of the Inspector General at HHS to submit a report on instances of fraud, expenditures, and savings. And that report request was included in our bill as well. I think that, if this bill passes, we'll understand the good, the bad, and the ugly, and how we can go forward with whatever policy we're going to put in place to make sure it's equitable, fair, accessible to everyone. But I know from speaking with you and speaking with other people how, collecting data is so important, but also being able to provide services, is so important, through telehealth or telemedicine, and how it's much more convenient for a lot of people. I've spoken to many doctors as the CDC Brain Trust Chair, spoke to doctors across the United States, and they said their patients come to the appointments more, they're not late, they're, they spend more time together, just all the positives. I know you can't do everything. I don't want you delivering the baby, but who knows? People have done that, when police have to deliver babies or firemen or whatever. But it really, I think telehealth improves the quality of medicine or the access, to care. And many people have said they don't have to miss work, they don't have to miss school, they don't have to worry about transportation or childcare. So, this was lifted up during COVID, and we need to make sure it stays lifted. And we also need to make sure, which there's bills that speak to this, that even after the pandemic is over, if it's ever going to be over, that we still keep up the pay that we're paying as if someone came to the office, because it's still taking your time and your expertise.
Yeah, exactly. So I was talking to a couple of my colleagues about this, and I wanted to get some different opinions, and they're still on my phone. But I was talking to Dr. Mia at Northwestern, and another friend, Dr. Goodall at Northwestern. And then I have actually another friend at Northwest Community out in the suburbs, and then another one in Indiana. So that's actually 4. And the prevailing opinion, after I asked everybody, how has it been during the pandemic? What can we do on a higher level, like on a policy creating level, in order to further the advancement of telehealth. Now, for OBs, it's a little different. So the biggest thing I noticed from most of my friends, and they're all doing OB, is how can we track their blood pressures? There are things like that, yes, there's wonderful things when it comes to being able to communicate, increasing compliance, but everybody doesn't have a fancy phone. I can check my blood pressure with this, but not everybody does. And that's why I kind of want to bridge a little bit to talking about the digital divide.
Mm-hmm.
I have a little statistic here, and this is just what I could find. Just 1 in 5 kids in Chicago don't have access to broadband. So during the pandemic, they weren't able to do their homework assignments. And that's like around 90,000 households on the south side of Chicago. That's a huge deal. Now, could you tell us and educate us a little bit about what you're doing to help to expand that type of technological access? So even if people don't have a fancy phone, we might be able to find a way to monitor vitals remotely.
Well, first of all, to your point about students, there is something called the homework gap, and that was 17 million students that didn't have access to do e-learning. And we did some maneuvering programs, laws, and it went down to 9 million, still way too many. And in the city of Chicago, what the cable folks did, they did something called Chicago Connects, but unfortunately, everyone still didn't take advantage of that. When we passed the bipartisan infrastructure law, a big part of that, beside roads, bridges, and tunnels, was broadband. We want to make sure that everyone has access to get online. And they have the foundation in their communities for broadband. So when we're done, every single person, whether they don't have it because they don't have the infrastructure or they can't afford it, we're going to make sure with this bill that every single person has it. So that's what we're working on, through the infrastructure bill. It's a jobs bill, a broadband bill, a clean water bill, plus the roads and bridges. So that's one really, really big program. We're also, the NTIA is now responsible for doling out 48 billion of new funding spread across multiple programs. And this funding will directly address digital equity and to ensure that all populations have access to high-speed internet and can take advantages of services like telehealth. So we know that was a problem. For me, my district is urban, suburban, and rural, and it definitely was a problem in my rural, but in my urban, financially, it was a problem, even though there definitely were some black holes, in the urban part of my district also.
Yep. One final question. We only have a couple of minutes left. So I'm just a regular doctor. I'm a small business owner, and I'm just kind of out here doing what I can do to help. What can we as regular folk do to enact some changes to address the maternal mortality crisis and help save mamas' lives?
Well, first of all, you are a fantastic doctor, not a regular doctor. You're a great doctor. Whenever we've called you, and there's others, you're always here supporting us, speaking for us at hearings and things like that. And that is so important because you are doing the work. I may represent you, but you are doing the work, and we need to hear the voices of people doing the work. And also we need people to continue telling their family, friends, colleagues to continue to show up in spaces like this, continue to keep their representatives accountable, not only on the federal level, but on the state level too. Illinois, they've done some great things as far as maternal mortality. I've worked with Senator Jackie Collins, Senator Castro, Rep. Mary Flowers, and bring these issues to the people, that represent you. And in particular, if you have friends and family that live other places that are not so Illinois-like, right, that their member has not supported, they need to hear from you. And we need to keep the pressure on, because the thing is, moms are dying every day. Families are missing their mom, their wife, their sister, stepmother, cousin, because of maternal mortality and morbidity. So this is a serious problem, And we're worse than so many other countries. There is no excuse.
It is embarrassing, but this is something that I am proud to work with you and do whatever I can on, that we can continue this dialogue, raise awareness, and enact change. So, Congresswoman Kelly, thank you so much.
Thank you so much. Thank you so much. Thank you for doing this.
Best.
Yes, Dr. Williams, thank you so much for taking time out of your very busy schedule to speak with us today. And Congresswoman, we so appreciate your leadership. We promise to keep working with you and fighting alongside of you until we can solve this crisis once and for all. Thank you so much.
Thank you, guys.
Next, I'd like to turn it over to Fran to introduce the panelists for our roundtable discussion on overcoming maternity deserts, the need for equitable broadband and technology access. Fran?
Thank you so much to Congresswoman Kelly. That was an amazing discussion with Dr. Williams, and we greatly appreciate you both. I'm so honored to be able to introduce our distinguished panel for our roundtable discussion. I know that we do have a few questions that were in the Q&A box as well. We do encourage you to send in those Q&A, and we will allot for some time towards the end of the roundtable to have those discussions as well. Today's roundtable is on the topic of overcoming maternity deserts, the need for equitable broadband and technology access. And thank you, Dr. Albero, for joining us. And we will have Mignon Clybourne to also join us onto camera, as well as Joe Cottrell. Dr. Joe Cottrell is an innovation strategist with AT&T. And we have one more panelist, Adamika, author, who will be joining us momentarily. So without further ado, we'll go ahead and get started with this discussion. And this is highly interactive. Those of you who have been with us for a while during our virtual Hill briefings, as well as our monthly meetings, will know that we like to ask for participation from everyone who's attending the program. It's not just for the panelists, so we're going to make sure there's plenty of time incorporated to allow you to equally participate. But we will get it started. We're first going to maybe chat a little bit about some of the points that came up through that dynamic conversation between Dr. Williams and Congresswoman Kelly. One of the things that stood out for me was the final remarks that came up, right? Those numbers of around 9 million individuals who were without access. I think she's actually started the number quoting 17 million, and how we were able to sort of get creative in creating for greater access. And that really speaks to some of the opportunities that exist. And so with that, I'd like to first allow for Mignon Clybourne. Mignon, if you don't mind, maybe kick us off. Talk to us a little bit, share us a little bit around the opportunities that exist there. And then we'll sort of dive into some other dynamics around what we heard from the Congresswoman.
Well, Dr. Fran and others, thank you for having me. So just a point of clarification. When the Congresswoman talked about those numbers, those were strictly school children. When you speak about the problem, the challenge of bridging the digital divide or providing connectivity in this nation, it is sadly way more significant by way of numbers. And that number is kind of squishy. And what I mean by that, you've got homes passed or technical infrastructure access versus actual connectivity, being able to forward it and having a continual relationship with the broadband provider and online access, and continual, because I can be classified as connected and I might have been online last month, but if I can't afford to pay the bills this month, then is that really connectivity? So the problem is vast. Proportionately, it's more significant in rural areas, but numerically, it's very significant in more by way of numbers in urban areas. So we're talking about a chronic challenge when it comes to 21st century opportunities and when it comes to persistent issues. And so when you talk about the last panel, three things, and I will make it quick, you know, that's not my nature, but I'm going to try to do it today. One, we are boasting at this stage a nation of the highest net wealth in the world. However, among developing nations, we've got among the highest, if not the highest, mortality rates too. These are chronic and devastating realities. Admittedly, some of the problems and challenges are complex, but they're fixable. And I think we walk into these spaces and think things are not fixable because they haven't been fixed before. They are fixable. Fourth, we're wasting a lot of time talking about the problem. Everybody knows what it is. It is getting worse, not better. And while I am not saying that there is no need for additional research and data, we've got the tools that are game-changing in other sectors and other neighborhoods in this nation, and it doesn't seem to trickle down. Got a little political there, and be more robust and ubiquitous when it comes to certain communities, particularly communities that are African American, Native, and low net worth. So we know what the problem is. We know where the problem is. We don't need a map to tell us where the problem is. What we need are the collection of the billions of dollars that are trickling down through the Infrastructure Act and the like. We need those to trickle over and come over my side of the tracks, because the reason why I have problems with some of block grants and some of these other methods of distributing resources from the federal government to the state, because it never, ever, ever got to my block. And so we need to make sure that there's an evenness and an equity and inclusion by way of those who are at the table. And that money needs to come over to my side of the track and your side of the track in order for us to tackle this problem, particularly when it comes to maternal health.
So, Mignon, I love your remarks on that, and they're so spot on. In fact, we had a comment and question that came from our participants that was around an acknowledgement of the great investment that was made in telehealth, and that during the pandemic, there was so much funding that was streaming down, but that much of the funding, much of the money, the technical assistance, the regulatory authority, et cetera, has really fallen away despite some of the clear potential to improve equity and care beyond the pandemic. And I know that can be concerning on many respects, inclusive of providers, healthcare providers who are, out in the trenches, on the front line, delivering care and looking to now, as best they can, sort of create a permanent fix hold, right? Telehealth and remote patient monitoring and other digital health solutions as a sort of a permanent place within the standard of care that they deliver to their patient populations. And with that, I'd like to ask for Dr. Cecilia Albero, who is a pediatric cardiologist from OSF Healthcare and their Children's Hospital of Illinois. So maybe step in here, Cecilia, talk to us a little bit about it from the lens of the provider, what you've seen, how integral has the technology and the infrastructure been, not only in the pandemic, but as you're beginning to look at sort of the modeling of care moving forward.
Thank you, Fran. And thank you, Congresswoman Kelly, for your diligence in fighting this good fight. As an Indigenous woman, a minority woman, and a physician, growing up in the Northwest and practicing as a subspecialist here in Illinois, I'm thrilled to hear that there's this bill to make tech equitable, fair, and accessible. Those terms, I wrote them down, tech being equitable, fair, and accessible to everyone, because I think as our future mothers are the children of today, those are the children that we take care of at Children's Hospital of Illinois. And this accessibility to care is very important to me. It completely did not shock me to hear the statistic that it's 8 times the maternal mortality in the state of Washington and 6 times in Illinois. So as somebody who spent a small period of my life on a reserve in Canada, this is not just an American problem, but a North American problem. Getting broadband access to healthcare to our most remote areas within America is a huge deal. So, Fran, to your question about during the pandemic, let me and beyond, let me talk a little bit about how specifically this has affected my practice. So during the pandemic, so part of what I do is I take care of the those that are referred to a pediatric cardiologist as let me back up a little bit and say I look at the fetal echocardiogram. So when obstetrics is looking for the 4 chambers of the heart, if they don't identify 4 chambers of the heart or abnormal outflow tracts, meaning that the great arteries are crossing abnormally, this means that a child who will be born would specifically have a significant heart condition that would require both a diagnostician, such as myself, to do the diagnosis and the healthcare portion there, but also a surgeon. And so, not being a surgeon myself, I partner really closely with our surgeons here at Children's Hospital of Illinois. So during the pandemic, this specifically meant that we had to find ways to keep moms safe before vaccinations from being exposed to this new and novel virus, but also to be able to keep our healthcare workers and providers safe. So tech kind of slid right in nicely. And I like what Mignon said about we have the tools. We literally do. We literally do have the tools, and the pandemic just highlighted that and kind of blew the top off that, yes, there are tools available. And oh, lo and behold, what we were told that we couldn't do telemedicine for years and years actually kind of almost changed overnight. So being able to see patients, not from the imaging standpoint, it's hard to do an image remotely at this point. You need those subspecialists to be able to look at the fetal heart and to be able to do that diagnosis. But it will come around the corner that there will be times that we'll be able to, maybe in the future, look at ultrasound remotely or blood pressures remotely. So these are the things that I think are around the corner, and having the accessibility to these. We want to make sure that we have the very right people at the table so that this can be something that is for everyone.
I love that. And you're exactly spot on, right? We're moving towards this place of hospital in the home. The notion of self-care, incorporating both self-monitoring, self-regulation, in addition to self-control. And so these things are really some of what we can look forward to seeing much more of. And we are beginning to see that with quite a bit of the technology. But as it was pointed out during Congresswoman Kelly's remarks, and as it was equally pointed out by Mignon, there are not only challenges with accessibility, but also literacy, right? Digital literacy, being familiar with the technology, knowing that it's available, understanding what your options are. And Adamika Arthur, we are so honored to have her join us. She's the executive director for Health Tech for Medicaid. And we'd love to get your thoughts, Adamika, on what you sort of see as some of the opportunities, particularly as we begin to sort of open people's eyes to what is available and sort of bringing them up to being empowered and aware of how they too can play a significant role in the care that they receive. Can you share a little bit of your insights on that?
Sure. Well, good morning. Thrilled to be here. And, as was mentioned earlier, I run a nonprofit called Health Tech for Medicaid. We sit at the center of where health tech and, health equity and tech equity kind of meet. And that is to really improve the quality, equity, and access to care, mainly for Medicaid recipients, which are some of the most vulnerable individuals in this country, the largest insured population, and due to the pandemic, a little bit over 84 million individuals at this particular point in time. But I think the issue around broadband access is one thing. Another thing around how do we allow folks to, we've talked about health literacy for decades, right? How do we help people become healthy, and how do we understand, like our understanding around social determinants of health, and how social determinants of health really impact about 80% of our health, right? The other 20% is kind of genetic. I'd like to expand that a little bit further to our economic determinants of health, our political determinants of health, and our environmental determinants of health. So when we add those spheres to it, it's more than just having access or having unmet needs. And Cecilia did a great job of talking about birthing people, right? And I say birthing people because there's a wide variety of individuals who birth children, right? Irrespective of gender. But we don't often talk about how do we navigate the system? How do we use technology as an enablement tool to improve our quality and our duration of life? And so we often just provide people with who have unmet needs, which many of us do, all of us do, right? And Mignon was explaining, like, even when you have resources, and the example of birthing people in this country shows that even when you have resources, your zip code literally defines your life expectancy. So it's not just having unmet need and having access, but how is that we're going to actually get to improving the health disparities? And that gets a little bit beyond. It allows us to think more than just providing broadband access. It is, how do we provide the tools to utilize broadband access? Because oftentimes as providers, and I'm an epidemiologist, we tend to ask people questions. Do you have access to the internet? Yes, I have access to the internet, and that's the end. But really, if it requires that my neighbor is home who has the computer in order for me to have access, that truly isn't giving the full story, right? It is that I'm reliant on someone else. My building may have broadband access. It doesn't mean that I have the device or the competency to actually utilize the tool to connect into the system. So we've got to, I think, as healthcare providers and the health system, beyond asking a lot more, but we have to actually start to, as industry, right? And throughout the ecosystem, really start to figure out, we move beyond health literacy and helping people to improve their health by knowledge and information, and extend that to tech literacy. And how can we help people utilize tools effectively to help improve their health?
Fran, I want to say something here, because I really appreciate what Adam just said. We have to be careful not to have this unhealthy infatuation with technology and connectivity. And I say that because the analog part of our existence is just as important. For me, being connected in these 21st century tools amplify, hopefully positive, complement, hopefully positive, but they do not replace, plain old literacy, plain old hand-holding, plain old, navigation, particularly when it comes to specialists, where we know people of color have the worst outcomes when it comes to this special maternity care. We know they do. So just getting to that specialist does not net necessarily a positive outcome if the rest of it that's analog centric is not there. So I want us to be careful. I've been in this technology business, for a while, but I know better, not to be swooned, by that. We have to be careful on that. Signing up in by
I think that's actually correct.
And connecting does not mean the world is going to be healed.
I'm so glad that you pointed that out, Mignon. And, oftentimes one of the things that folks hear me refer to is this idea that for many older adults, as an example, for whom we want to push a lot of technology on, there's sort of two dynamics. Number one, added burden to personal caregivers. And number two, really, we're replacing what for some people is the only time that they leave their home, is that interaction with their clinicians when they know that they're going to have when they're going to have their medical visits. And so we really do need to be more cognizant of and recognize that hybrid models are very, very much the key to having long-standing, sustainable programs. And so I'm really grateful for you pointing that out. And one example where we see this in communities is particularly when it comes to creating for things like digital literacy, is creating environments where older adults, as an example, have the opportunity to come together and learn about technology. And they are oftentimes hosted by groups like telecommunication manufacturers. We have one with us today. We have Joe Cottrell, who is Joe Cottrell is with AT&T. Is involved in innovations. Joe, I'd love for you to share sort of your thoughts on the opportunity, particularly as it pertains to the role beyond the technology that you see providers of telecommunications playing in ensuring that not only is there access, but also that things that are supportive more broadly around the integration of technology are provisioned as well. So, what's your
Yeah.
thoughts?
Thanks for having me, by the way, too. And it's so great to be a part of this panel. And it's interesting because that's kind of my job. I'm a strategy and innovation director for a technology company, but I work solely within healthcare services, whether it's providers, which is a big part of who I work with, or it could be medical devices, payers, those kinds of things. And to have technology without that business value or without that healthcare noble goal in mind is really not what solves problems anymore. And that's why I'm here. I sort of translate that technology to the use case, and some of the opportunities we see there certainly do have technology underpinnings, like Congresswoman Kelly was talking about improving the data, so then we can do the actions that data mandates us to do. Or not everybody has a phone. And in fact, those numbers we were talking about, what's the scope of the opportunity here? I think the Commerce Secretary in the Affordable Connectivity Program put the number at an estimated 30 million that did not have proper access to the internet. So the opportunity here is not just to get the technology where it isn't, it's to do more than that. It's to improve things like virtual care. And one of the benefits of telehealth and virtual care is also seeing into the home life, seeing how those persons interact and how they live, which brings on lots of other determinants of their health, those kinds of things. So whether it's prenatal with telehealth or access to subject matter experts via these remote types of technologies, or whether it's using patient-generated health data for blood pressure that we've talked about, or heart rates, those kinds of things can now be instrumented, and with proper connectivity, that data can flow in, which allows us to do those better analog processes to bring that level of care up for those underserved populations.
Mm-hmm, mm-hmm. Indeed, it does.
Can I add? I was just looking in the chat, and I thought that kind of piggybacked really well onto the question that I had in my own mind was, how do we go ahead and create safe spaces to learn from each other? How do we go ahead and have these resources so that people aren't left behind, so that kids aren't left behind, so that children that are suffering on their own tech devices at this very instance, who are in these islands of isolation, who feel so much like that they're alone, and that the scary statistic of the suicidality is rising in young people and females and young girls these days. So how do we create these safe spaces for tech? So it's more than just the accessibility to it. I think it's the humanness around it. And I know there are people out there that are trying to work at this from different angles. I think the former founder of, whether it was Twitter, Tristan Harris, is trying to start something called Humane Technology. Things like that are out there. But as a clinician, as somebody who has young kids, it does kind of scare me that we're in uncharted territories. We don't always know what it is that we're creating.
So let's talk about that a little bit, Cecilia. Let's explore some of the challenges that exist, right? And bring along with those challenges sort of your perspective on ways to address, because as Mignon mentioned, we can just talk about all the challenges are there, or we can get on to some solutions. Sure. But I'm thinking in particular about some of the research that we've conducted, both globally and certainly hyper-focused here in the United States, that looks at physicians and their adoption of digital health technology. And some of the studies, one of the well-known studies, which is the digital doctor study that's conducted annually every year since 2015, one of the things that we sort of find are these concerns. We talk about the Dr. Google and clinicians being concerned about not being ready, right, to be able to address the concerns that arise out of patients being self-informed. I'm curious what your thoughts are in relation to challenges that you might see when we begin to talk about integrating digital technology more into self-care practices, and what this means in terms of both the readiness for patients, individuals, women, as well as for providers who are delivering care. Particularly as you think back to some of the examples you gave with the use of, for example, remote use of ultrasound. Talk to us what some of the concerns or challenges that you see might arise from that and how we might be able to begin to circumvent some of those challenges.
Great. Wow, there's a lot to unpack there. That is a lot of detail and questions. So kind of backing up a little bit, I might have a different perspective than some of my other colleagues in regards to how they feel as a provider of information and those that might get information from the internet. And how do I feel about that as our patients are coming in and Dr. Google per se? I think it is an important tool that's accessible to many, many people, that they're able to get onto their internet and maybe research something like a cardiac defect. What that brings, though, into the next forefront is that people come to our offices with a level of anxiety, perhaps, about what they've read and about what the next steps are. So as a provider, as a clinician, that's sort of the fun part of my job, is being able to either kind of talk around those concerns and fears and maybe provide a level of reassurance, or to step it up to really going into depth. And so I still think that even with tools and techniques, whether it's an ultrasound at home, whether it's information from Dr. Google, as of right now, I don't think that physicians are going to be written out of the equation. I might be wrong on that, but it doesn't scare me. Tech doesn't scare me per se, in regards to those things at home. Now, the other question that you had, I'm trying to remember exactly how you worded it, but about the ultrasounds, about what those next steps are. I think that those technologies are very much around the corner, but how to, so I'll give an example of something that we do use in our patient setting. Is there's something called maternal lupus and neonatal lupus. And so for those patients, we will send them home with a heart rate detector. So they'll go home with, and it's something you can also buy over the counter too, but just a fetal heart rate detector. And so when we give those tools to families, we also have to give them our cell phone and personal number, so that when they go home and they're detecting a slow heart rate, because that's what happens, is heart block can happen with those that have a slow maternal lupus patients, can then, long story short, is that the antibodies can attack the fetal conduction system. So that means that the baby itself can then have a pretty serious problem. And so that's a tool that is at home being used, but it can be scary to know how to use it. So when I see that there's a question.
Dr. C, when you talk about, that, it makes me think that all of the other things need to work alongside that too, meaning Medicaid reimbursement rates need to be aligned, and incented, so that those wearables and monitoring devices and tracking equipment, that is saving and life, altering, that those signals are sent there. You made me chuckle, Fran. I went ahead and out of Mika. That's my nature. So we'll talk about it. You can punish me later. But I thought about, and I've done this to my clinician a lot. I'll go in and say, I have such and such. I have diagnosed like several syllables that only can be, probably found in the tropics or somewhere that I will never live. And he said, you do not have, whatever. You probably have this. And so, to me, if you have a good rapport, then that is received in a different way, not as an affirmative. I've never attended, I didn't do well in science, but I have research because I'm going like, I've got a headache. Maybe I have Lyme disease. I don't, and it was something way more complicated than that. But what I'm saying is, if we have those baselines, and this is an analog, I keep going back to analog as much as I'm, connected and being an enabler of connectivity. It's the analog relationships that's going to make this truly work. It is the analog legislative and regulatory policies that will make us work. The reimbursements, making sure that those laws are interpreted for the best use at home. When the president signs that bill, that's just the beginning. That's not an affirmative. That's not in stone. It's the application that's going to make this all work. And if we don't have a seat at the local tables, because remember this, this latest round of funding, $100 million is going to the states in the form of block grants. Are you at the table? Are you speaking to your governor? Is your legislator working on your behalf? Is your mayor, sitting there and say, here, over here? If that's not happening, we're going to spend billions of dollars and have the same challenges. I think that's wasteful, and hope you do too.
Well, and that's where we have to begin to co-design with communities, right? We talk about, and there's a role for everyone to co-design, right? Like as you were talking about, Cecilia, and as I know, I ran hospitals for almost 15 years in this country, right? It is important to co-design with our community, and co-design means some things we really need to get back to patient-centered, consumer-centered, people-centered methodologies, because actually that is why, even though we have unmet need, even though we have our disparities have gotten worse. Our disparities have gotten worse because we disconnected from the knowledge of the community. And so, Mignon, you mentioned something very critical. You had a rapport with your clinician where they could at least listen to your concern, right? We have to listen to our communities. Technologists, innovators who are creating products cannot fit a square peg in a round hole. You have got to listen to the people that you are actually creating products for. If you're policymakers, you need to ensure that we are doing either, maybe not community-led work, which I think is gold standard, right? But community participatory methods for sure, and definitely co-design with neighborhoods and communities so you understand that money that's coming down will actually be utilized well. Having kiosks in places where people are never going to go is not going to be a good use of funds, right? And so oftentimes we measure the wrong things. And data is my love language. I'm an epidemiologist, right? But we can measure ourselves to death and not be improving the lives, not just the lives, the quality and duration of lives of individuals. So I think we need to move back to learning how to center on the individuals we actually want to improve. And I will use a very easy public health example. We all can cross the street in about 99% of the US, right? Meaning that young child, somebody in a wheelchair, somebody who's blind can pretty much cross the street. We create pedestrian crossings so people can cross. Now, in some places, in urban areas, we've got bells and whistles, and if you got auditory messages, and some places have that really cool colored line in the middle of the street. But if we can get down to designing for the least common denominator for everyone's good, we will get a heck of a lot farther, and we will save more lives. We will save more money so we can save more lives.
I think a comparison to that too is while we're trying to improve that analog interaction, the technology does come in as far as assisting with access. So whether it's the example of crossing the street, there are curb cuts and there are lines painted. So bringing that technology access allows for that person to person. And one of the things we noticed at the beginning of the pandemic was that virtual care ramped way up, but it still was not the underserved communities that were using virtual care. It was people who had the right fancy phone, as was discussed earlier. So some of the things now that is right around the corner as far as being able to bring these technologies in is to take something that was clumsy over the past 2 years as we had to implement virtual care and make it more elegant, enterprise grade, make sure the reimbursements are in the proper place to allow this horse that's out of the barn to run free. And the way that we've started to do that is by making sure that equity of access is there as table stakes to be able to bring in these other services over the top. And whether that's the affordable connectivity broadband, or whether it's using first responder mobile networks, like we've done a lot for remote patient monitoring to bring that in over cellular. It makes it, whether it's rural, tribal, or inner city, you can get that access in there on day one.
But I will just stress, design with the community, because the only way that it will be utilized is that. The reason why it was never utilized before is because we did not have access. So, and even now, when we're building these fancy bells and whistles on top, right? Make sure we are connecting with those who we're actually trying to solve for. Not solve for them, solve with them. That is the only way.
I think that's a really great point. But I think that there's an element that's also very critical. It's not just about initiating and planning along with as part of the design. And it's not just design, it's universal design, but it's also that it be an ongoing engagement. So a lot of times what you see, particularly with technology development and even with the development of new policies, is we may bring a group together, a focus group, or bring in representatives or co-chairs from a variety of communities, but they're only in place for a temporary period of time. And to create for long-standing programs, it really necessitates this ongoing engagement and reevaluation and continuous improvement measures. We had a comment from someone, one of the participants, who made the remark that technology can also be used to empower the last mile. The community initiatives, for example, in the current, it's heartbreaking to me, the current formula shortage that's going on. I'm sure many of you have heard about that, the baby formula, that there's a shortage crisis, that knowing for WIC moms, as an example, who need formula, to be able to reach out to them simply through the use of text technology, to ask them about their situation, and to make sure that we go then to the last mile to deliver what stocks are available, and that we're integrating and ensuring that state and local WIC offices are gathering places, and that they are reaching out to folks. But it could be much faster way to address the mother and child crisis that we're experiencing right now. So I want to thank Veronica Adamson actually for sharing that with us, because that's a prime example where even, we've spent time here talking about high tech and no tech, but there's also that low tech opportunity with just really simple things like SMS messaging, which we could begin to utilize so much more and stay connected. I can't believe that we are at the end of time today. And well, I guess I can, because we've had a phenomenal panel, right? You guys are amazing. And we had an outstanding discussion with Dr. Williams and Congresswoman Kelly. And we want to, again, thank them again for their time today. I hope everyone enjoyed. We always like to have a wonderful wrap up at the end. So it's my pleasure to invite Elizabeth Frazee, who is one of the co-chairs, to take it home for us. Elizabeth?
Hi, everyone. What a fabulous conversation we've had over this past hour and 15 minutes. And starting with the fireside chat, Dr. Williams and Congresswoman Kelly just really provided us fabulous insights. And Congresswoman Kelly left us with a call to action, which was echoed by Mignon, to really go and talk to your representatives, both at the local, at the state, at the federal level. They need to hear from you. Quoting Mignon, I think, Mignon, you said that analog relationships matter. And that means writing your member of Congress, talking to your mayor, catching them when you see them at the grocery store, or your city council members, because those analog conversations are going to really make a difference to address this overwhelming problem. It's one conversation at a time, like this fantastic conversation we've had today that will make change. So just wanted to thank all of our guests. You've been terrific. Thanks to Fran and to David, and to putting together this fabulous program. So with that, I think we're at time. Thanks all.